and thank you so much for joining us today for the NEMICS Annual Forum. My name is Anne Yeomanson, and I recently had the pleasure of acting for NEMICS Director Linda Nolte for a 7-month period. Linda, welcome back again, and thanks for asking me to MC tonight. It's week 2 for you, so I'm sure you've been really busy, and it's a pleasure to come in and help out with the forum today, so thank you. So we have a varied program today and a really good range of speakers that we think you will enjoy. Our theme for today is delivering impact. And the first session of our program will look at the year that was, and then we'll hear from our first feature speaker, Catherine Harper, who is an evaluation and monitoring consultant and the director of Crondar Consulting. And Catherine will provide us with an overview of how to evaluate the impact of cancer care. After a break, we'll turn our focus towards presentations, including our second feature speaker, Dr. Diana Lewis from Northern Health, and also some discussions around the coming year. I'm pleased to welcome Cameron Goodyear, the Interim CEO of Austin Health, and the NEMICS Chair to formally welcome you and set the scene for cancer care in our region. Over to you, Cameron.
Thanks, Anne, and good afternoon, everyone. And as Anne said, my name is Cameron Goodyear. I'm the Interim CEO at Austin Health, and I am delighted as Chair of the NEMICS Governance Group to welcome each and every one of you to the 2024 NEMICS Annual Forum here today. It is great. I'm just looking down the list of attendees. It's so great to see representatives here today from our 4-member services. So obviously Austin Health, but Eastern Health, Northern and Mercy. I do want to formally welcome our guest speakers and thank each and every one of them for their time and supporting today's forum here today. And also welcome to our NEMICS staff and importantly, a number of consumer representatives that we have on the line. Welcome to each and every one of you here today also. In opening today's forum, I want to begin by acknowledging the traditional owners of the land. Here at Austin Health, we're meeting on the lands of Wurundjeri people of the Kulin Nation, and I pay my respects to their history, traditions and culture. I want to welcome any First Nation peoples here at today's forum or any First Nation peoples attending across the member health services today. So, as we're all aware, NEMICS, so the North East Melbourne Integrated Cancer Service, is one of 9 ICs in Victoria. Each IC strives to deliver, I guess, a statewide or a network-wide approach to support local cancer service improvement initiatives. We'd like to think NEMICS strives to be a dynamic network, a program that engages, that learns from each other and collaborates amongst the partnership to really work towards and achieve a shared vision that we all have around improving cancer outcomes for our community. So in financial year 23-24, NEMICS continued to invest in delivering quality cancer service improvements initiatives, and really those that are aiming to be sustainable and deliver real impact for our community. Some of these included, and we'll hear a little bit more about some of these today, but some of these included service improvements through co-design with our member services, professional development grant programs, evidence translation to inform future work, and initiatives that connect our member services with state and national service development opportunities and priorities. Additionally, NEMICS has again hosted 2 statewide functions on behalf of the VICS this year. So namely the VICS Statewide Communications Office and also the Optimal Care Summit program, which brought to bear their experts from across the state to identify unwarranted variations in cancer care and prioritise some actions to address them. So during today's session, will we hear more about the work that NEMICS has delivered in the past year, and where perhaps we envisage impact can be achieved into the coming year and beyond. So this forum also coincides with the online release of the NEMICS Annual Report, and so I do invite each of you to have a look at that. The annual report will be sent to all of you post this forum, so please look out for that in your emails after this session. So, as Anne mentioned, I just wanted to spend a little bit of time setting the scene, particularly for our next speakers, Anne and Mel. I'd like to share with you some stats. So on the screen now, you can see the significant growth that we've had in cancer service demand across the last 9 years across the NEMICS partnership. In 2023, over 54,000 public cancer admissions occurred across the NEMICS member services. And you can see there it is a little bit of a busy graph, but I did want to highlight some of the key points. So of note, there was a 24% increase in malignant cancer bed-based admissions at the NEMICS public hospitals during the period shown. So that's the green line, and you can see the uptick even post-pandemic in 2022, but importantly in 2023. The Northern, as obviously one of our member partners, has seen the most notable increase in cancer admissions, and that's depicted by the yellow line. You can see there that has really increased, particularly in the last 2 years. I think importantly, to support meeting the need and meeting this increased demand, the NEMICS member services have grown in terms of the number of multidisciplinary meetings. So MDMs that obviously oversight cancer care. You can see the growth there, which is the orange line at the top. You can see the growth over the last few years, obviously a bit of a pause or plateauing during the pandemic, but then again, particularly in 2023, increased again further. So there obviously is increasing demand for our services and for cancer care, and I think this increased capacity, in particular in relation to the MDMs, reflects our dedicated clinical teams and their commitments to patients receiving the highest quality cancer care, and also importantly, the multidisciplinary collaboration that happens in that space. So it has been a busy year, and more than likely demand for cancer care will continue to grow into the future. However, our services and the NEMICS partnership will continue our dedicated work to meet that need, and also try and ensure as much as possible to provide safe and effective care models that provide impact in terms of cancer care. So I just wanted to share this data today to set some of the context for the rest of today's forum and the important improvement initiatives that we've had, particularly in the last 12 months. So I want to welcome everyone again to today's forum and sincerely thank you for making the time to attend. And I now hand back to Anne or Mel Greco to take us through the rest of the forum. So back to you, Anne. Thanks.
So Mel and I are now going to kick off 2023-24 in replay, first of all by sharing some of the year's highlights ourselves, and then by introducing you to some of our member services staff who received NEMICS service improvement grants this year. And those three staff will provide you with a Fast 5 presentation on the improvement that they delivered with their grant. So we're looking forward to that from Andrea, Carolyn, and then Emily. As Cameron flagged in his opening, NEMICS is one of 9 Victorian integrated cancer services serving the northeast Melbourne council areas of Banyule, Burundara, Darebin, Knox, Manningham, Maroondah, Nolumbic, Whitehorse, Whittlesea and Yarra Ranges, a really diverse and large geography that they cover. The NEMICS region's residents seek care from across the region's 4 health services, Austin, Eastern, Northern and Mersey, but also via other public services in other ICS regions, as well as through the private health system. In the NEMICS annual report, we describe our region's current level of self-sufficiency, inflows and outflows, in other words, our corridors of care. And this travel is fairly normal in cancer services. It enables clients to access specialist care, clinical trials and a range of other things available across the state. Inflow of consumers from the northern region of Hume is a particular feature of our patient flow that we provide more information about in our annual report. One of the things that we're looking forward to next year will be the release of the Department of Health's Cancer Services Capability Framework. And the framework will provide an opportunity for cancer services to self-evaluate their current capability and also to identify their corridor partner needs as we move into our future health system. In 2023 and 24, together with our member services, NEMICS delivered a range of initiatives and improvements to cancer care. All work was aligned with the Victorian Cancer Plan 2020 to 24, which Wanda will speak to a little later in our session today. And there was a focus on 3 of the 5 pillars on the plan, which you can see on screen now. So improving equity of access to high quality care, supporting implementation of optimal care pathways, and improving wellbeing and support for Victorians affected by cancer. The work was delivered by 5 key methods, which were 12 service improvement projects led by NEMICS, the Optimal Care Summits program, a range of evidence building work pieces with a particular focus this year on vulnerable populations, including the culturally and linguistically diverse. The provision of 59 professional development grants and also 11 service improvement grants, which we provided to member services for them to lead and drive work internally. Mel and I are pleased now to show you some highlights of those 5 different work streams that NEMICS has delivered this year. So in terms of the 12 service improvement projects, these projects have assisted in a range of areas, including MDM quality, supportive care and survivorship access as well. One example project delivered in 2024 has been the NEMICS facilitated transition of all 16 of Eastern Health's MDMs to the CoolVic information management system. Shout out to you, Phil Parente, and I don't think we have Michelle with us today, but thank you for the amazing partners you are over at Eastern Health. NEMICS worked closely with Eastern Health's Cancer Services Chair and Leadership Committee to facilitate project and change management and to support a number of aspects of technical implementation. With the support of the Department of Health, CoolVic training was provided to staff on essential tasks such as patient referrals, scribing during meetings and accessing meeting documents and information. And the outcome you can see there on screen, that now Eastern Health have access to additional patient information via the platform connections that CoolVic offers, for example, to pathology services, and they have a greater means to more accurately monitor and analyse performance metrics across their MDM system. We'll move now to our 3rd pillar of Optimal Care Summits. So this year, the VIC's Optimal Care Summits program has continued to bring together subject matter experts from across the state to identify unwarranted variations in care, investigate their meaning, and to generate an action log to result in their address. And I'd like to take this opportunity to recognise the Optimal Care Summits program manager, Helena Roddy, who is very capable and just delivers such a professional and highly regarded program through the Optimal Care Summits. This year saw an esophagogastric summit, which examined a number of unwarranted variations and resulted in the genesis of our first formal and comprehensive action register, which lists work that the ICS will undertake and that a number of our lateral partners such as PanCare and Cancer Council will also do in support of addressing those variations. One of the really pleasing things to see at this year's OG Summit was that we were able to compare data from a previous summit back in 2016. And so the comparison of 2-3 year periods of data showed the enormous increase in MDM meeting rates that you saw earlier that really supports quality care. That in fact in the esophagogastric space they had exceeded the Department of Health target of discussing 85% of patients. And also that statewide mortality and 1 and 5 year survival rates had all improved in a very meaningful way since that previous period. And at the May 2024 Cancer Australia launch of the Australian Comprehensive Cancer Care Network, the Optimal Care Summits program was presented and recognised as an exemplar nationally of how to drive high quality cancer care. I'll shuffle out and pass you to Mel.
Sharing. Hi, thanks, Anne. So an understanding of NEMICS member service populations profiles helps NEMICS and its members to deliver culturally safe and appropriate care. Language is one area, an element to consider. This graphic on the screen shows the top 3 languages other than English spoken by our consumers at each of our 4 member health services. As you can see, even with the NEMICS region, there is linguistic diversity, let alone cultural and other diversities. That must be factored into how care is provided. Aligned to its commitment to develop evidence for service improvements, NEMICS this year reviewed the most recent results of the Victorian Cancer Experience Survey to guide future improvement work. Insights were sought regarding Aboriginal and Torres Strait Islander, culturally and linguistically diverse, LGBTQIA+, and adolescent and young adult cancer patients. Themes across these groups included, but were not limited to, a need for timely information, a contact if concerns arose, greater access to interpreter services, as well as additional privacy and focus on communicating respect. This information is now being discussed with other member health services with a view to addressing it in future work. This year, NEMICS has provided 59 professional development grants, several of which have assisted staff to build their skills in advanced cannulation. This was an area of opportunity for skill building, which has been identified within our member health services, and NEMICS was well positioned to provide the support. A NEMICS grant was also crucial in helping Eleanor Wilkies enhance her ability to promote quality care that aligns with sound research by completing her graduate certificate in leadership and management at the Australian College of Nursing. Eleanor gained essential clinical and decision-making skills to provide high-level care in complex circumstances at Massey Hospital for Women. You can now see on screen the 11 service improvement grants that NEMICS have provided to its member health services this year. To continue our 2023-24 year in replay, I am delighted to now introduce 3 of our grant recipients to provide a Fast 5 outline of their project and its outcomes. Firstly, I'd like to introduce Andrea Morrison. I hope I get your title correct, Andrea. It's really long. You are the Stream Leader, Transition and Maintenance Stream Senior Clinician, General Medicine at Austin Health. Thanks, Andrea.
Good afternoon. I'm delighted to be able to present on behalf of our project team. This project would never have been completed without the funding we received from NEMICS, so I'd like to start by thanking NEMICS for the opportunity. I would also like to acknowledge the importance of the NEMICS Grants program in providing funding for clinicians like myself to help us to ensure we continue to provide high quality care and outcomes for people who've had a diagnosis of cancer. The background of this project was a concern within the clinical team working in the Austin Health Palliative Care Unit that the physiotherapists may not be involved with the right patients. Obviously, we wanted to ensure there was no service gap. But who are the right patients and how do you measure benefit? This project was designed as a scoping project to provide the foundational work to help answer these questions. But before we could answer the questions, we had to really understand who was admitted to the Austin Palliative Care Ward. Data is already being collected routinely as part of clinical practice, and we wanted to see if this data could be accessed and that it was robust enough to be able to be used to answer clinical questions, especially on trajectory. The two main databases we used were the Austin Health Clinical Data Warehouse and the Palliative Care Outcome Collaboration, or PCOC database. This is a national collaboration which uses validated standard assessments for palliative care settings. We specifically wanted to see if the raw Austin site-specific data could be accessed and used to gain information on function and clinical stability. We looked at the 800 admissions in the 12 months of 2022. This provided a rich data set for us to examine. The most striking ward demographic was the mortality rate, which was sitting at 81%. As yet, we haven't compared this with other palliative care wards, so we're not sure how unique this is. We also found that physiotherapists weren't reliant on referrals received from other members of the treating team. In total, physios were involved with about a quarter of the patients admitted, and over half of these were not referred by others, but identified by the physio team independently. The people the physiotherapists were involved with were a very different cohort from the whole, as shown on this graph. As you can see, there's a significant difference between the two curves, both in the slope and the gap between them. Now, if this was describing a medication, then everyone would be rushing to use that drug. However, I think we can all agree that physio intervention, no matter how good and magical it might be, does not have a direct impact upon mortality in this cohort. So what we're really seeing here is that the physiotherapists were extremely good at picking the cohort of people most likely to survive longer. The group seen by the physiotherapists' mortality rate was 59% as opposed to 86% in the other group. Next, yep, thanks. From the PCOC data, we use the AKPS assessment. The AKPS is a measure of physical function, and as you can see, the physiotherapists were involved with people with higher scores. Clinically, this translates to people who are able to actively participate in treatment and are likely to have the physical reserves to tolerate it. You can also see that there was a greater percentage of people discharged from this group. Another part of the PCOC assessment rates clinical stability. As you can see from the colours, the areas coloured green, the physiotherapists were involved with people who remained in the stable phase significantly longer. An interesting difference between the groups was the cohort that was seen by the physiotherapists had significantly higher Charlson index scores and more comorbidities. The Charlson is used as a predictor of long-term survival, a higher score indicative of a worse outcome. This seems counterintuitive, but perhaps suggests that the physio assessment has a very different focus. Our key findings. Next slide, thanks. It's feasible to get access to the data already collected and stored at Austin Health, and that the data is robust enough to answer clinical questions. The physiotherapy assessment was able to identify a very different cohort of people within the whole in terms of survival and discharge. The best part of the project for us was when our Director of Palliative Care said she felt a huge relief that the people most able to participate and tolerate physiotherapy interventions, and thus probably benefit, were the ones that were being identified and seen. Unexpectedly, when we ran all the variables of diagnosis, Charlson score, age, etc. through our model, the strongest predictor of survival was whether a person received physio or not. We hypothesised that the physiotherapist's use of a validated frailty assessment, which includes an understanding of a person's function in the 2 weeks prior to the admission, is a significant factor in their ability to prognosticate. And to finish, I wanted to recognise the project team and our wonderful and wise steering committee. Everyone whose name you see played a role in delivering this project. The project relied heavily on the expertise of Dr. Jennifer Jones to extract raw data and to build usable databases. And without this, we wouldn't have had any results to report. And I wanted to especially thank our 2 consumer representatives, John Clements and Catherine Kelly, who were major contributors to our steering committee. That was a lot to get through in 5 minutes. I hope everyone managed to understand what I was saying, and thank you all for listening.
Thanks so much, Andrea. Next, I'd like to introduce Olivia Power, who's Clinical Project Lead at Mercy Health.
Good evening, everyone. I'm presenting on behalf of Mercy Hospital for Women, who received a service improvement grant aimed at enhancing the supportive care screening rates among our cancer patients. We are deeply grateful to NEMICS for granting us the opportunity to undertake this essential project. Their support, along with the collaboration we received across various departments within the hospital, has been instrumental in our success to continue to provide high quality care and outcomes for people who have been diagnosed with cancer. Supportive care screening plays a pivotal role in identifying the unique needs of cancer patients, allowing healthcare providers to offer comprehensive and tailored care that addresses not just their medical condition, but also their emotional, psychological, and social needs. Unfortunately, our analysis revealed that the supportive care screening rates at Mercy Hospital were well below the expected targets, partially due to an introduction of scanned medical records taking away visual cues, COVID, and low staff training. This meant that a significant number of patients could have been missing out on vital support services that could help them navigate their treatment and improve their overall quality of life during such a challenging period. With this grant, our primary objective was to elevate the supportive care screening rates to an ambitious target of 80%. This aligns with the Department of Health's guidelines, which emphasises the importance of supportive care in enhancing patient outcomes. Achieving this goal would not only ensure that more of our patients are properly assessed and supported, but it would also foster greater satisfaction with the overall care experience in our hospital. By focusing on these improvements, we aim to create a more compassionate and responsive healthcare environment for those facing cancer. To address this challenge, we implemented a multifaceted approach by completing an in-depth review to what we were doing and identification of barriers to screening. We revised existing procedures to ensure supportive care screening became a standard part of patient care and made the process of supportive care screening more straightforward to staff. We created an alert flag within our patient management system, which allows healthcare providers to quickly identify which patients have not yet undergone supportive care screening, facilitating timely intervention. We updated our inpatient ward journey boards and handover sheets to include supportive care screening status. This ensures that all team members know each patient's screening status during care transitions. We initiated a supportive care screening champion role, and these champions are responsible for promoting screening within their teams, ensuring compliance and facilitating discussions about patient needs. We developed localized training materials to educate staff on the importance of supportive care screening and how to implement it effectively into their daily routines. Clear expectations were set for staff regarding the completion of supportive care screenings, fostering accountability and encouraging a culture of supportive care within our organisation. This cultural shift has enabled our team to be more responsive to our patients' diverse and evolving needs. The outcomes of our initiative have been truly remarkable. Over the span of less than 5 months, we successfully increased the supportive care screening rate for chemotherapy patients from just below 50% to an impressive 87%. This significant improvement highlights not only the effectiveness of our targeted strategies, such as enhancing training for staff, streamlined communication processes, and increased patient outreach, but also underscores the unwavering commitment of our dedicated team to prioritising comprehensive patient care. Their hard work and focus on addressing the needs of our patients have been instrumental in achieving these results, ultimately contributing to better overall patient outcomes. So thanks everyone for listening.
Thanks, Olivia. Next, I would like to introduce Emily Minopoulos, who is the Leukaemia Coordinator, Clinical Nurse Consultant at Eastern Health.
My name is Emily Minopoulos, and I am the Leukaemia Clinical Nurse Consultant from Eastern Health. Sorry I couldn't join you in person at the NEMICS Annual Forum. I'm up in Queensland at our National Haematology Conference, so please enjoy these slides in my absence. My NEMICS Service Improvement Grant was the development of an outpatient venetoclax model of care. So for those of you unfamiliar with haematology or who are unfamiliar with leukemia treatment, venetoclax is an oral medication used to treat adults with newly diagnosed acute myeloid leukemia who are 75 years of age or older, or who have medical conditions that prevent them from using standard chemotherapy. Management of patients beginning treatment with venetoclax has been largely inpatient-based. With advances in the understanding of leukemia and treatments, as well as improvements in supportive care, patients are increasingly being managed in the outpatient setting. So with this in mind, I decided to use the existing Eastern Health Leukemia database and perform a comprehensive data analysis with the aim of establishing a new pathway which would move the delivery of venetoclax from the inpatient setting to the outpatient setting. This would also help to achieve a more patient-centred model of care. The key findings of my project were that patients that will benefit from the new model of care are evenly split between males and females. The average age of patient that will benefit from the new model of care is 74 years old. However, the age range varied from patients in their early 50s all the way up to those in their late 80s. The average length of stay for patients receiving venetoclax ramp-up dosing as an inpatient was 11 days. Therefore, the outpatient venetoclax model of care will move care of these patients to the outpatient setting, saving an average of 11 inpatient days stay per patient. And 82% of patients that received venetoclax ramp-up dosing as an inpatient had at least one emergency department presentation post-discharge from hospital. A key element of this newly developed protocol moving forward is to further prevent avoidable ED presentations and continue to establish a process for facilitating direct inpatient access when necessary for patients receiving venetoclax in the outpatient setting. Patient quality of life is a key driver of outpatient hematological care. Instead of being defined by their diagnosis, patients can simply factor it into their lives. After a diagnosis, being able to receive treatment in an outpatient setting can give patients some normalcy in their lives. It provides a sense of flexibility for patients. If the only benefit patients obtain is remaining out of hospital, that alone can literally be life-changing. Thank you.
I'm really pleased to introduce our first feature speaker, Catherine Harper, who's the Director of Crondar Consulting. Catherine is a public health epidemiologist with extensive experience both internationally and nationally in government, academia and consulting. Catherine is going to share some valuable insights into the cascade of evaluation and monitoring measures that connect through from the Victorian Public Health and Wellbeing Plan all the way through to cancer services, the VICS and beyond. Having worked with Catherine before, I know we can expect some really clear and actionable information for evaluating impact. Thank you, Catherine.
And thank you, Anne. I hope you can all hear me. Just let me know if you can't. So thank you for the opportunity to talk today and to have this discussion around how you can demonstrate the impact of the VICS. So I'm going to address these 5 points here. But as Anne said, in addition to the first point, which is what are the key concepts of monitoring and evaluation of impact, there are some overarching high-level frameworks to use in addressing how to measure the impact of VICS. So if we think about the 3 key concepts of monitoring and evaluation, I'm going to talk about definitions. So what is monitoring? What is evaluation? How do they link? The outcomes approach and what that means, the what, the how, the who, the why. And then another core concept for thinking about demonstrating impact is what is your accountability for change? And by addressing and understanding your accountability for change, you will then generate actionable insights from your evaluation and monitoring in order to lead to better decision making and improvement. So monitoring and evaluation are not the same thing, although they are often confused and lumped together as if it is one thing. Monitoring is a subset of evaluation. Evaluation is a large, planned, periodic, point in time, purposeful activity that looks at information right across the results train, from inputs, activities, outputs, impacts, outcomes, all of it together, and analyzes it and systematically reviews it all. It generally includes numbers and words, qualitative and quantitative data. Monitoring is a subset. Monitoring, again, is systematic. It's a systematic process of collecting and analyzing and using information through a project, a program, a strategy to track progress and impact using very specific defined indicators. So it is a quantitative process regularly done, whereas, say, an evaluation could occur at a formative stage at the beginning, halfway through, and then as a summative stage at the end. It is not a continuous process. Monitoring is a continuous process and is used for interim decision making. So if we're talking about measuring the impact of VIX, one of the key questions is, what is the time frame and the scope of the measuring of your impact? The other core concept that I just wanted to touch base on, and I'm sure this is not a new concept for any of you, but let's think about what is an outcomes approach. So when we say we're measuring impact, we're measuring effect, we're measuring outcome. So taking an outcomes approach is about focusing on and measuring what matters. So we know where we want to go, the light on the hill. We set ourselves on a path and we follow that path with decision making along the way through a monitoring process. And the evaluation talks about, did we get to the light on the hill? So an outcomes approach requires that you be really clear about and focus on what you want to achieve. And that can be in the short term, the medium term, or the long term. But exactly what do you want to achieve? It requires you to determine who, or the population group, which is at the center. And speaking in a health context, is it about the population broadly? Or is that about patient change, individual patient change, watching your corridors of care and your patient outcomes as an individual? So who is at the center in your monitoring and evaluation? And then you measure progress along the way using impact measures. And they are, again, providing useful information, actionable insights. There's a whole separate part to all of this, which is not the outcomes approach, but it's how to achieve the change. And that's about your process measures, your outputs, that sort of thing. And that's captured in your strategic plans, your operational plans, and the like. That's the how. Whereas the outcomes approach is the what. What do you want to achieve? And then another question is, why did the change occur? And that's another core question for measuring impact. And that question of why the change occurred is captured in intermediate outcomes using program logic. So we know from an evidence base, if this happens, then it's expected that this happens, expected that that happens. So using that program logic, you can consider how that change could have occurred and think about, are you talking about change for the entirety of the population or person-based change, which person-based can aggregate up into the population of patients, but it's a different cohort. So that's a very quick summary of taking an outcomes approach, which is all part of measuring impact. The other core concept for monitoring and evaluation is this concept called measuring the right impacts or assessment and accountability for change. I break change into 3 categories. There are changes for which you control it. For example, different interventions of multidisciplinary teams. Do you have the staff available? What do those teams do? There's a direct link between the program and the change. So they're under the control, and they're under the control of a project, or more broadly under the control of an X. Then there are changes that you can influence. You don't control them, but you have influence. And that influence can range from very strong influence to much more subtle influence, and uses a vast variety of techniques, from advocacy and other ways you can influence with your partners and within your organizations. So that your accountability for change on those things you influence is lower than your accountability for change where you can control it. And then there are other changes that occur which are contextual. You don't influence them, but they're really important as direction setting, as goal setting, and allow you to see the broader context within which you work. So there are 3 types of accountabilities for change, and knowing what you control, influence, and what is contextual is all part of deciding how you're going to measure impact, by understanding what are you accountable to change. So if we look at the changes for which you can control, they are most useful for decision making because you're right there, you can control it. But if you only look at the changes you control, you miss the bigger picture. You miss all that context that's happening around you and all the things you influence. So if we move to measures to achieving change through things you influence, that shows the influence of your partnering, your advocacy, and other collaborations and other processes, but it too misses the bigger picture. Whereas contextual changes, measures of contextual changes, provide that bigger picture and show collective impact. So again, thinking about how you're going to demonstrate impact, think about different changes that you are seeking in an outcomes approach within the control domain, the influence domain, and the contextual domain. So just as examples of the sort of measures that you would have under control, you have a fair degree of control over some components of the patient experience. You have a fair degree of control over some of the components of optimal care adherence. So they're control. If you look at influence, you influence survival rates for cancer. You influence the death rates for cancer, but you don't control them. There are many other factors at play there that influence cancer death rates and survival rates. And then looking at contextual measures, cancer incidence is a very, very important piece of information for the planning of your services and for goal setting and the like. But it is a contextual measure. Other way to look at that is smoking rates. Smoking as a risk factor for cancer is very strong, but you don't influence smoking rates in your population. But it's important you know what it is so that you can measure and consider future practices. So that's the 3rd part of the core concepts that I wanted to just touch base on, lightly touch. So I'm going to talk about the Victorian cancer-related monitoring frameworks that we have and look at each of those in terms of what they contain, how they're reported, and the implications for the VICs. So I'm going to start at the very pointy end, at the top of our triangle, which is the Victorian Public Health and Wellbeing Outcomes Framework, which is about the entirety that impacts public health and well-being for the entire population of Victoria. Again, that's a big light on the hill, some distance apart, some distance away. And then we have the Victorian Cancer Monitoring and Evaluation Framework, which is a population-based framework for the state of Victoria. Then we have the VICS Monitoring and Evaluation Framework, which is much closer to home here and articulates through to those other frameworks. And then we have the Optimal Care Pathway Tumour Summits and the report we heard discussed earlier. So they all articulate through, and I hope to show you some of the lines of context that they lead together. So the Victorian Public Health and Wellbeing Outcomes Framework was published in 2016. I'm not sure how many of you are familiar with that, but that is this very large overarching framework. It has been reviewed in 2014. So it covers 5 domains, which, as you can see on the screen there, are very broad. It captures outcomes, indicators, there are targets, and there are measures. That framework, parts of it are reported annually. It has never all been reported on, and there are some measures that are not developed. So it hasn't been implemented completely as planned. However, importantly, it informs the 4-year Victorian Public Health and Wellbeing plans, which mostly focus on risk factors and focus then on the core risk factors for cancer. Considering the actual measures in the Victorian Public Health and Wellbeing Outcomes Framework, there are cancer relevant measures of prevalence rates of the cancer risk factors as listed there. There are the proportion of adults, adolescents and children with very good and self-reported health. These are very broad measures. There's HPV 3-dose vaccination coverage, which is a tighter measure in relation to cancer. And there's premature death rate due to cancer. So again, thinking about things that are contextual and things you influence. There are some of those there, but most measures from a VICS perspective are contextual. But the measures provide line of sight to the goals and achievements at a whole of Victorian level. And that's where the Victorian Public Health and Wellbeing Outcomes Framework sits. The next framework I'm just going to touch on is the Victorian Cancer Monitoring and Evaluation Framework. So if we think about that in a hierarchical sense, it grabs some of the measures from the Victorian Public Health and Wellbeing Outcomes Framework and expands very broadly in the focus of cancer. So there are nearly 100 measures across 17 result areas and 7 outcomes. It is a very broad framework. It is a monitoring framework only because it is based upon quantitative measures reported moderately regularly. As you can see, it's 2018, 2020, 2023. And it looks at a population level, at an outcomes level. The data for the Victorian Cancer Monitoring and Evaluation Framework, which really should be called the Victorian Cancer Monitoring Framework, is reported by ICS in a geographic sense across the state, and it's reported for the state by sex, male and female, by low socioeconomic to high socioeconomic quintiles across the state, for remoteness and specifically for Aboriginal Victorians. So there are some measure of more vulnerable populations included in the reporting of this framework, and also some measures that relate to geographic difference. It doesn't go to explaining why those differences occur because it is a monitoring framework. It states where those differences are. So the Victorian Cancer Monitoring and Evaluation Framework uses many databases, which I'm sure many of you are very familiar with. And importantly, it uses some linked databases, which again is a very important way that we can aggregate information around individual patients and the impact of individual services through a program logic approach. However, what is widely discussed and acknowledged is there's actually limited access to primary healthcare data. And within that framework, there's very little primary healthcare data. Nationally, this is recognised, and through the Australian Institute of Health and Welfare, there are a number of projects being undertaken to try and develop linked data through from the hospital systems, through the primary care systems, through the registry systems and the like. One project is the National Primary and Acute Care Data Linkage Project, which is working on linking GP data through to incidence, hospital data and incidence data. But that's a major gap in this framework and in many other frameworks. So if we think broadly about within the cancer monitoring and evaluation framework, what are the hospital related measures? So these are measures that the hospitals control and measures that the hospitals can influence. And I haven't separated them in this, but there are many, many measures within the cancer monitoring and evaluation framework that show the impact of hospital work or the influence of hospital work. So there are death rates, there's increased survivorship quality of life, there's equitably reduced cancer deaths. So the inequities are looked at in premature deaths, again by ICS, SES, and for Aboriginal Victorians. So trying to see the inequity across the state of Victoria in cancer deaths. And then a domain area is increased adherence to the optimal care pathways. There are many, many measures in the framework that report against for increased adherence to optimal care pathways. Those relate to, they start at days from diagnosis to primary curative treatment, go all the way through to specialist palliative care, aggressive interventions within 30 days prior to death, and proportion of deaths due to cancer that occur in hospitals. So there are a large number of measures in the cancer monitoring and evaluation framework that would inform demonstrating impact in the hospital of cancer. Of note, there are a number of measures within there that are not developed. The data is not available. So there is a distance to go in order to report against this framework. However, it is in train, and there are plans for the generation of much of that data in subsequent years. The other measures that we've got is survival rates, 1 and 5 year survival rates for all cancers and specific cancers, and then survival rates, whether they're diagnosed at stages 1 and 2 or stages 3 and 4. So there's a lot of definition within that work there. Improving quality of life with a health-related quality of life following primary treatment score, which is available then for ICS. Another domain is improving patient experience of healthcare, and there are a number of measures in the framework that relate to the Victorian Healthcare Experience Survey, as well as the Cancer Experience Survey. And then there is a section on innovations and improved evidence of best practice. And again, they are very relevant to the work of clinical trials within hospitals. So there's a lot within the cancer monitoring and evaluation framework that can be used to assess or consider the impact of the VICs and demonstrate that impact. So the data is published publicly for the ICS geographic areas and includes public and private hospitals where data is available. NEMICS and other ICS are provided with unpublished data for many of the indicators that can be assessed at that level. For each NEMICS health service, each of the 4 in your specific case, some measures are provided by locality of residence, and others by the treating hospital. Because you can imagine the data can be cut in both ways and tells you different pieces of information. It does not provide insight into why there is variation between population groups and the geographies that we are provided data with. It looks at the indicators one after the other and does not, by design, assess a patient corridor of care or a patient pathway and look at why there is variation in these groups. That would be the subject of an evaluation, not the subject of a monitoring framework. So it's important to know what it is you're seeking. Are you seeking to monitor or are you seeking to evaluate when you think about demonstrating impact of the VIX? The next framework I'm going to talk about is the VIX Monitoring and Evaluation Framework, which you may not have heard of, and Anne has told me that. It was drafted in 2022 to provide a consistent statewide VIX approach. However, it was never finalised. It is under review and has never been reported against. But the framework in its draft form provides lots of very useful information for you to consider if you're looking at demonstrating the impact of VIX. This is not about demonstrating the impact of an individual project like we have seen very expertly done in the 3 projects we've seen earlier in today's session. This is about thinking at the level of the X or the VIX. So the VIX Monitoring and Evaluation Framework is a merged monitoring and evaluation framework with extensive data collection requirements. So it's a very resource intensive framework to implement. It includes output and impact measures. It covers appropriateness, effectiveness, and efficiency. So it is very broad in its reach, and not unrelated to that, it requires extensive data collection and is resource intensive to implement. So it's not something that would be done regularly, annually or the like. It is a very large project to implement. It does provide very good program logic on achieving each of the pillars of the Victorian Cancer Plan that was in process at when the outcomes framework was developed. And it provides output, short-term and longer-term outcomes. So it's a very interesting place to start or to consider when you're thinking about demonstrating the impact of the X. And the last type of assessment of impact that I wanted to consider is the Optimal Care Summits program. So as you know far better than I do, it's to cover about 20 tumour streams and it's releasing about 3 per year is the plan. It is a very, very comprehensive evaluation based on mixed methods, inclusive of a literature review, consumer groups, consumer surveys, implemented data collection systems, as well as used existing data collection systems. An excellent, very broad approach to measuring impact. Very resource intensive to do, and thus can be done for very small areas of work in a programmed release like you're talking about, but will not look broadly at demonstrating the impact of VIX. It will be a deep dive, an excellent deep dive, but it's not at the level of measuring the impact of VIX. Okay, so in that fly path, what have I talked about? I've talked about some of the key concepts of monitoring and evaluation, their definitions. What's that outcomes approach? Thinking about measuring impact, you're thinking about what you want to achieve and being really clear about that and focusing on that. And acknowledging what changes the VIX are accountable for. that accountability for change lens is an important lens to put over any framework or systems you put in place for demonstrating impact. We've talked about 4 frameworks. The Victorian Public Health and Wellbeing Outcomes Framework, there's some monitoring annually. It's contextual, but it's an interesting and informative light on the hill with direct lines through to hospital-based care and the VICS. The Victorian Cancer Monitoring and Evaluation Framework is reported more regularly, is much more relevant to the VICS. It has population-based hospital impacts for locality of residence and for treating hospital. And it also contains broadly contextual measures. So it includes measures for which the hospitals can control change, for which they can influence change, and contextual measures. So a broad monitoring, not evaluation, monitoring framework. The VICS monitoring and evaluation framework, though not implemented, does contain good program logic and broad evaluation strategies for demonstrating the impact of the VICS, but would need to be reviewed as it is being reviewed, I understand, by the department in some time frame. And then you have the optimal care pathway tumour sonnets, which are a very comprehensive, resource-intensive impact evaluation of a specific cancer. So it's a deep dive looking at the impact of VICS, but it is not appropriate for a broad assessment of demonstrating the impact of the VICS. So if we think about what are the questions that should go through your head when you're thinking about how do we demonstrate impact of the VICS, and this is applicable also for thinking about demonstrating impact of a project. You just slice it down. Firstly, any sort of a framework you develop to demonstrate the impact of the VICS has to be evidence informed and based on best practice care. That's very clear. It has to be fit for purpose. So know your purpose. Are you looking for monitoring? Are you looking for evaluation? Are you looking for broad population reporting, even at a treating hospital level, which is a population, and then there's geography and the like? Or are you looking for patient corridors of care, pathways of care, and outcomes on a pathway of care paradigm? So consider those issues. And then when you've determined its purpose, any sort of framework has to balance comprehensiveness. You cannot measure everything. It's impossible and inappropriate to measure everything. So balance comprehensiveness, need, and the reporting burden. It has to provide actionable insights, useful information, good for decision making, has to be actionable. The measures that you include have to be beyond SMART. And we all know that the SMART is specific, measurable, assignable, as in somebody's got responsibility to do it. It's not assignable as in accountability in that acronym. Realistic, you can get change, and it's time related. We need to think beyond SMART to think about some of those issues, and it has to be aligned with the level of accountability for change. Thank you.
Thank you so much, Catherine. I feel like I've been on a very groovy E&M helicopter. I've soared up high. I've looked at all the places that I could set my landing target and where I could land, and have really thought about what it is that I want to, where I want to be, and find that light on the hill. And I think the other reflection I had was just, you know, the contextual influence and control Also highlighted to me why we need to work with partner agencies. So, for example, agencies that do health promotion might be able to influence smoking rates, which for us are contextual, but for them, they may be able to influence in some way. So our partnerships and working as a whole health and wellbeing system is so very critical. So welcome back, everyone. Our second section of the program is now going to turn to be very future-facing. And to kick off, I'm delighted to welcome Professor Wanda Stelmach, NEMICS's Clinical Director and also the Divisional Director of Medical Cancer Services at Northern Health, to talk about what's next.
Thank you very much, and it's good to see the people online and joining us here. And also, first of all, I'd like to thank Anne for covering Linda's absence for 6 months and supporting Umbreen and myself in the works we've been doing and progressing that work that Linda started. And wish you all the best in your next career steps. And also welcome back, Linda. You left off 6 months ago. I hope you've come with your sleeves rolled up. There's lots to be done. So where to next? September saw the release of the next 4-year Victoria Cancer Plan, and it builds on the previous plans we've had. The VIC's vision and the vision of the Victorian State Cancer Plan are actually aligned, and that is optimal and equitable cancer outcomes for all Victorians. So to me, that means that no matter where I live in Victoria, my cancer journey is assured of the same quality and the same outcomes, irrespective of whether I'm rural or metro. So the cancer plan once again lays out the key priorities for a wide range of government-funded cancer services, including the VICs. Over the next 4 years, our work is going to be aligned with the 5 pillars you see on screen. Themselves particularly well to the work we do, albeit that in some areas, like in primary prevention, it isn't our main focus. However, this gives us a real opportunity and opens and strengthens that opportunity to work with our community partners. So we intend to keep working on that optimal and equitable access to care across the entire cancer pathway. We can also be involved in secondary prevention, working with patients around better health generally. We can also be involved with driving cancer screening through patients we see and through their families. Bowel, breast and cervical programs are quite well established, and next year we will be seeing the lung cancer screening program. And also we need to work more closely with consumer-facing health promotion organisations around education. And so one of the focus we dedicated this year's NEMICS Annual Report is on the data section, which I do recommend you read. So it examines the trends that in demand over the past 9 years. And as Cameron showed you earlier in the graphs, that there is a growing need, as well as visualising what our NEMICS residents use both within our region and outside of our region. So there's concepts of corridors of care, which you can see in that graph. It's typical for people to move in and out of their local government area for a number of reasons, including access to specialised care and to clinical trials. So what we really have to do is enable patient care close to home, and there lies our opportunity in working with our health service partners in increasing their capability around managing self-sufficiency locally and keeping the patient close to home. So for the last 4 months, we've been working with our health services to prepare us to develop the VICS and the NEMICS work plan for the next 4 years. We've been able to deliver, as was said, the gastroesophageal cancer optimal care pathway, and we already have 4 in the plans: endometrial, colorectal, head and neck, and hepatocellular cancer. So they will all be rolled out next year. We are continuing to explore what other opportunities we have to improve equity and quality. And for example, looking at colonoscopy access and the quality dashboard, which will be presented to you by Northern Health lead, Dr. Diana Lewis, shortly. And you can see the potential benefits from this program, not only to the individual patient who might well be better reassured that the endoscopy they're undergoing is of equal standard to anywhere else in Victoria, but also would reassure health services that the care they're providing is of equal quality. There are other potential supporting works we can do, looking at the incoming National Lung Cancer Screening Program and how we can work with our community partners and what we need to do within our health service partners as well. Also improvements in MDMs. You noted, I hope, on that graph that Cameron showed, that the number of patients are increasing, the number of MDMs are increasing. There is finite capacity, both financially and in staffing. And so how can we improve the efficiency of MDMs so we can keep this high quality standard we currently have? So it might mean looking at what other software rollouts we could have, advocating the Department of Health regarding enhancements, and looking at the opportunity of how can we modify MDMs. So, for example, do we have to discuss every straightforward case that first needs to go to surgery? Other ideas we can explore are improving cancer care experience and outcomes, especially in the communities that are at risk. As you can see, the Aboriginal and Torres Strait Islander community experience, but we have information around the CALD communities, the LGBTQI communities. However, those are our ideas and we are a team. And so we really welcome your ideas for the priorities for further work, and are really interested in where you think we should be focusing in the next 12 months, and then working towards a project that might take longer to develop. Breen's going to take you on that exploratory journey shortly. We're going to hear from Diana Lewis about the colonoscopy dashboard, where she describes the benefits of this project, not only to patients and to endoscopists, but to health services as well. So Diana, I'll pass it over to you.
Thanks, Wanda. At Northern, we've created a real-time colonoscopy quality dashboard that has all the quality indicators in it. So colorectal cancer is the fourth most common cancer, and polyps are precancerous lesions in the bowel. And colonoscopy can detect those cancers, and by those polyps, and by removing them, about 70 or 80% of colorectal cancers can be prevented. And interval colorectal cancer is cancer that occurs before the next date of the next colonoscopy, when they've already had a clear colonoscopy. So I'll just flick through a few things there. Colorectal cancer is expensive, and late-stage colorectal cancer costs a lot more. So the quality of colonoscopy varies significantly, and it can be very operator dependent. And there are some key quality indicators for colonoscopy, including bowel preparation quality, cecal intubation rates, which is the percentage of colonoscopies where the cecum is fully intubated, and then adenoma and serrated polyp detection rates. The adenoma and serrated polyp detection rates is a percentage of colonoscopies where an adenoma is detected and a percentage of colonoscopies where a serrated polyp is detected. And if all of these are improved, then the rates of interval colorectal cancer are decreased. Now, because the quality of colonoscopy varies significantly, auditing is mandated by the Safer Care Victoria and the Australian Colonoscopy Clinical Care Standards. So at Northern Health, we used to have an endoscopy nurse who would audit every single one of our colonoscopies and calculate our adenoma and serrated polyp detection rate by manually checking each report and histology report. And it took them 6 weeks a year full time to do this auditing properly. In other places, they use junior doctors to do it. Some places they don't perform audits regularly, and in other places very low numbers are audited. If auditing is done properly, it would cost over $1 million over 5 years with staff time, but that doesn't take into account the negatives if auditing isn't done. So poor auditing can significantly compromise patient care, so you risk not detecting poor performance or detecting it late. And there were over 2,000 colonoscopies recalled for a single endoscopist in rural Victoria a few years ago. 1,000 of these patients had repeat colonoscopies, and 7 of those had bowel cancer, which is extremely high, a very high rate of interval colorectal cancer. The other aspect is the loss of trust in healthcare. So I see a lot of patients in my private rooms from rural Victoria, and especially in that area where there were a number of patients recalled for repeat colonoscopies, patients don't want to receive their care locally and do come down to Melbourne for endoscopy, which I think it's just that loss of trust in healthcare is major. So the solution is using automation. So Northern Health have developed a real-time dashboard that includes all of the quality indicators with the adenoma and serrated polyp detection rates, cecal intubation rates and bowel preparation quality for the health service and each individual endoscopist over time, along with waitlist data and outcomes data as well. So this is the colonoscopy. If you could just press play on the thing. And so this is the opening dashboard. It has the number of patients who were referred for a colonoscopy, those who had the procedure within a timely fashion based on their category, as well as the overall just data about the procedural outcomes, such as the bowel preparation quality and cecal and adenoma and serrated polyp detection rates, as well as some complication data too. So looking at those who have had their colonoscopy within the appropriate time frame, we can see based on different health services what percentage are having it, as well as for each subcategory, how many are having it within the recommended time frame. And we've got similar data as well for those having more emergency procedures, as inpatients more so. For our bowel preparation quality, the clinical care standards would say 95% is what we should aim for, but as a health service with our very complex patients, we accept 90% as our cutoff. And the bottom graph has a whole heap of columns, which is each individual endoscopist and the number of colonoscopies that they've performed in the time frame, all de-identified. And then the line is the bowel preparation, the percentage of patients with adequate bowel prep that they've reported. Similarly, the cecal intubation rate, the bottom graph has each individual endoscopist with the line at the being the percentage of colonoscopies where the cecum was intubated. The dashboard's interactive, and you can see that if you select just patients with inadequate prep, the rates of cecal intubation go down significantly. For our adenoma detection rates, again, similar graph with the columns at the bottom and the line being each individual endoscopist. The bare minimum for adenoma detection rate is 25%, which sort of most people are meeting. And we can look at the data in a lot more detail with the actual raw percentages for each de-identified endoscopist. If you select one endoscopist, they can look at their data in more detail, looking at it over time and looking at over shorter time frames as well. And you can see this endoscopist in the last financial year had only 80% of patients had adequate prep, and adequate preparation is actually after time has been spent washing and cleaning the bowel. So obviously they've seen that data, they've improved their rates of washing and cleaning the bowel, and have improved this financial year their bowel preparation quality rates. And along with that, their adenoma and serrated polyp detection rates have both gone up as well. So the benefits are that it's time saving, you don't have to do any manual auditing, the data is live, and the auditing is far more likely to occur. I think if we're actually auditing, we can actually make sure that the provision of healthcare and quality of endoscopy that we're providing, no matter where people access the endoscopy, will be the same. Because it's real time, we can monitor new endoscopists and any endoscopists who require improvement if we change any procedures such as bowel preparation instructions, and we can detect and address any issues in quality early and reassess it as well. So ultimately, I'd propose that it'd be fantastic to roll this out to some other health services as a pilot study, and then hopefully roll it out sort of Melbourne and statewide, and then even Australia-wide ultimately. And it would allow for benchmarking of quality between health services as well. To be able to roll this out to other health services, we'd need some sponsorship and partnership, as well as support to roll this out. And we would need some extra staffing hours, I suppose, to actually be able to do this. And the health services would need electronic endoscopy and histology reporting to be able to have this dashboard up and running. We are doing some other work looking at creating a REDCap database to sort of use in some ways for endoscopy reporting, which is underway at the moment, creating a data dictionary. Places around the world are also quite interested. So gastroenterologists in Mongolia are looking to set up something similar, that I'm working with them for that as well. And there's also opportunity for other dashboards, such as assessing the indication for endoscopy, gastroscopy quality indicators, and advanced endoscopic quality indicators are some examples. So I'd just like to acknowledge these people. Leanne is on our digital team and has done a huge amount of work creating the dashboard as well. And Melissa, Will and Ben all sort of went through thousands of patients' data to double check the accuracy of it as we were creating this dashboard. So thank you.
Thank you so much, Diana. And well done, Northern Health, and all whilst we saw early on during Cameron's session how the activity at Northern is just booming through the roof. So I imagine that makes it all the more necessary, but also challenging sometimes to take time out and do these projects. But well done on bringing together your clinical skills and your operational, strategic and technological thinking. It's amazing, and yeah, it's very inspiring to see work like that. Are there any questions?
Thanks, Diana. Excellent presentation. I just have one question. In terms of how does it account for complexity of the case? Do you also collect data about their comorbidities to determine, what's the complexity from one hospital as compared to other? For example, tertiary centers may see more complex and complicated patient as compared to the other hospitals.
So we are reliant on the data that's collected as part of the Victorian admitted data set. And that does include some of the Charleston Comorbidity Index, but that's also reliant on data that's entered within admissions and things like that. So there is some aspects of endoscopy that we can see the complexity of patients, but we haven't included that in the dashboard because it is data that's so reliant on so many different things that it's not the best quality data and not that accurate.
Thank you. Linda Nolte?
Yeah, thanks so much for a great presentation. Hopefully you can hear me okay, can you? Yep, great. I just had a question because you started off about the importance of doing this auditing and for safety, and I was wondering what is Better Safer Care Victoria saying about this particular platform, because this is excellent, and I'm quite interested to understand what their buy-in to this piece of work is. Thanks.
So we did present it to Safer Care Victoria, who were quite interested, but it's sort of just nothing much has happened.
There's certainly an interest. I think we do have to do a proof of project with potentially a pilot. We've got a couple of metro services and rural interested to see how we could roll that out in a smaller pilot and then where it might land. But it certainly has improved the clinicians' sort of recognition of the work they need to do in their own upskilling. There was first resistance around it, but I think now they're very much more open and have seen the benefits of being able to talk to each other about, why they have different rates, what they could each do to improve things. equally, from the nurse's point of view, it's really released them from a very boring, mundane task and with the registrars to allow them to go back into that clinical area. So it's benefited patients to have the nurses back in the clinical platform rather than collecting data. And it is real time. We don't have to wait 12 months and then we're 12 months behind in the results. So there are lots of benefits, and I think there are benefits to look at, you know, are the current requirements the absolutely best quality requirements. It allows us to review all of that, and there have been already some changes in what is required to be collected through the Gastroenterological Society.
Yeah, thank you.
Thank you very much. I would perhaps hazard a guess too that the last 6 months plus has been an even busier than ever time at the department and SCV. So, you know, I know, Wanda, you've got plans to sort of continue those conversations with Diana as well. So, yeah, we look forward to seeing this pilot turn into a scale up, because it's too good a piece of work to not be scaled up. So well done, Diana, and all the team at Northern Health. That's a great example of an initiative. Now is hand over to our Deputy Clinical Director, Dr. Umbreen Hafiz, to facilitate a little bit of discussion time around that forward-facing piece. Umbreen is, as I say, our Deputy Clinical Director and also an oncologist here at Austin Health, and she's been a real driving force behind a lot of our evidence development work and thinking about the needs of vulnerable populations, and plays a really important part working with our clinical project managers, our data staff, etc., to piece together the puzzle of improving cancer care. And Umbreen, I hope you don't mind if I attempt a little joke and just, you know, say people may recognise you after your recent appearance on Channel 9 on Today Tonight, talking about your research during the Olivia Newton-John Walk for Wellness Week. So on that note, I hand over to someone who is more than 5 minutes of fame. Go, Umbreen.
Thanks, Anne. Thanks for a very kind introduction. So good afternoon, everyone. So I know that this is, you know, kind of a last part of the conversation. We had an excellent forum. We had, you know, learned speakers. And I have to say that I have learned a lot today from Diana and from Catherine. Thank you so much. Excellent presentation. And Wanda, your insight. And I would again thanks Anne for all her work in the last 6 months, and you know, welcome Linda. You know, we have got very exciting times ahead of us. I think I just want to end this session with some sort of a brainstorming. I think all of us had something to eat, so we have got a bit of a post-prandial dip. But you know, we can think about it, we can do it quicker, and then we can go home earlier. So what I want you to do is I want you to think about what do you think we can do in 2024, 2025, like statewide or network-wide or as local cancer service initiatives. What area of impact, if somebody had any thoughts about it, just share your thoughts. So you can either raise hand or you can write in Q&A.
We can see from where we started today that we're going to see increases in patient numbers as our population continues to grow, and you know, demand for all sorts of aspects of cancer services. And you know, I can envisage doing a real planning piece around that demand and what it will look like and what the strategy will be for services to actually meet that demand.
Thanks, Anne. I think that's a big challenge for all of us and for government as well to meet increasing demand. This is the right time to advocate for meeting demands for cancer patients as well. So thanks, Anne. That's a very good suggestion. So who is second? So Linda, you are the first one, and Wanda, you would be after that.
Yeah, and that's a really good point about the demand. I think that that extends across so many aspects, doesn't it, of the patient journey and care. And you know, we really have quite an issue around demand and capacity within the MDMs. And I think for us, it's really important for us to be doing a piece of work in that space. I mean, we've obviously done quite significant improvement in the MDM space, and we're really thankful for all our partnering work and efforts across the VICs as well as across NEMICS and across our individual member health services and each MDM. It's been amazing to see the progress that has been made. But, you know, if we think, is it by you know, in the next 20 years, we're going to have some approximate 50,000 new cancer cases across Victoria, and needing to have those cases treated with best practice methods, which includes MDMs and supportive care and survivorship and everything else. We certainly do have significant demand and capacity and workforce related to those aspects of care that is going to be needed. So really need to explore workforce. NEMICS is really keen to help ensure that we have a very capable workforce. And you know, we do that also by supporting professional development grants, which will become available again soon. So thanks.
Thanks, Linda. So, I mean, NEMICS, yes, as we know, NEMICS are already doing work in the MDM space, and I guess we can continue to support that and, you know, progress that. I'll go to the next person who put the hand. I think it was you, Wanda. So.
Yeah, I mean, we've got a few consumers online. I'd really be interested to hear from a consumer point of view, because we've been talking very hospital-centric, health service-centric, but I'd like to hear from anyone online who's a consumer. What are your thoughts? How do we support the cancer journey? And the other part of the question is, given the difficulty in acquiring staff, given the financial constraints, which won't change radically over the next 12, 24 months, in spite of an election, we are going to have to depend on more, for example, digital ways of supporting patients through the cancer journey. And I was just wondering, what is the community feeling around digital pathways, digital support?
Not a consumer, but spoken to a lot of consumers during a project I did with BCCC and also with the NEMICS. You know, what people want is people want a quality care close to their home, and they want more support. You know, yes, we talk about metrics and whatnot. What a person wants is that he or she is able to go for screening. There is support available. They can go to their GP with, you know, increasing cost of GP services. It's becoming difficult now, not having bulk billing services. They are able to come to the hospital and they're supported in the hospital. There is a support person in the hospital to help them, and they're provided quality care, and there is an adequate follow-up. And they are supported in this journey. And I think it comes back to a lot of gaps in terms of funding for support for people who have cancers. Like, we don't have a lot of cancer care navigators. I think these things comes again and again in terms of cancer care navigators who can help people with the CAL communities, navigator who can help people with ATSI or people with other disabilities. That's my view when I have spoken to them, but we probably have to talk to them again to get their opinion.
Thank you, Ambreen. And certainly my experience of when I talk to patients and we talk about wellbeing programs, and a lot of the times, especially with patients who've had a complex pathway to either a diagnosis of cancer or a clearance of a diagnosis of cancer, the frustrations they feel around the multiple appointments, you know, with diagnostic or therapeutic appointments, outpatients appointments, how there's that lack of coordination and support while they're in a very anxious state, not knowing what is going to happen to them. So I think that, and you know, that's part of that optimal care pathway, that first bit how do we support patients into the entry into the cancer diagnosis so it's timely, so it fits with the guidelines, so there are earlier diagnosis of clearance of a diagnosis, because that supports their mental health as well.
Well, thank you so much, everybody. And then next, if somebody wants to share with us, what was it which grabbed your attention today? I have to say that I can start. I have to say that I loved Andrea's presentation. I have to say that I did not know that palliative care patients in palliative care units, you have the physiotherapy. You can refer them to physiotherapy. You know, remember when we see patients, when we palliate them, you know, we don't think of the referring them to physiotherapy. So thank you so much, Andrea. That is going to be action from tomorrow.
I agree with you, Umbreen. That's and if we're going to look at palliative care, not in the last weeks of the patient's life or even last days, it's really supporting the patient on a journey to give them the best life they have. And if you know, exercise and physiotherapy supports that better quality of life, then I really think we need to look into that. So yeah, I really found that a fascinating study.
Exactly. I've changed my practice from tomorrow about that.
Yes.
All right. Well, I think we come to a close. So I'll hand back to Anne.
Breen. To close, thank you again, everyone, for your time today. I hope you enjoyed the various presenters. Please reach out to us. We really appreciate any contact through email, through phone, etc. And as we mentioned earlier, Linda Nolte, the Director of NEMICS, is back on deck, and so Linda can capably coordinate a response to all the thoughts and ideas that you have as we continue to firm up the work plan for the next 12 months and beyond. I'd also like to just acknowledge in particular our consumer advisory group members who are here today. Thank you so much for coming. When we were going to meet in person, we had intentions of having a bit of a formal thank you to you, but that's taken a different shape because we've gone online today, but we look forward to thanking you when you meet next as a consumer advisory group. And we're excited by the work that Mel Greco and Samira Arif and others in the team are doing with you to really enable you to contribute in all the ways that you feel passionate about as well. So thank you. Following today's session, everyone who has attended will receive an email, and there will be the link there to the NEMICS annual report, which, as Cameron mentioned, has been released, and there'll also be a link to a survey about tonight. And even if you fire through it really quickly and just give us a couple of clicks and one comment, and that would be really awesome and help to shape future forums as well. And to all our members services, thank you so much for letting us walk the journey with you. I have really thoroughly enjoyed getting to know all the amazing people from our services. I won't name you because I'd hate to forget somebody. That would be terrible, but you know who you all are. It's just been a delight. Please allow us to walk with you and support your existing efforts and your strategic plans. NEMICS certainly doesn't want to overlay additional activities. We want to actually be an enabler and a help to you. So keep reaching out and telling us about what matters to you anyway. Thank you, everyone. I think that brings an end to our proceedings. So good night.